Good morning, everybody. My name is Cole Harrell. I'm a third-year pharmacy student here at Wingate University, and I want to take just a moment to wish all of you a good roll tide. If you're not from the state of Alabama, that means good morning. And welcome to everybody that drove several hours to be here. I appreciate it very much. So today we're going to be talking about Simeprevir and the use of hepatitis C. It's a new drug that's recently been approved, but before I get into it, I want to just mention I have no relevant financial or non-financial relationships with Janssen Pharmaceuticals or any other companies to disclose at this time. So today we've got a couple objectives that we want to go over. First of all, I want to be able to identify the pathophysiology and the clinical presentation of hepatitis C, which I may refer to as HCV at this point, just for short's sake. I'm also going to summarize the standard of therapy for HCV. We're going to go over a little bit of historical as well as some recent changes that happened 4 weeks ago. We're going to discuss the mechanism of action, the pharmacokinetics, dosing, and adverse effects of Simeprevir. We're going to evaluate a couple of clinical trials. They're going to study the use of Simeprevir in treatment of genotype 1 HCV. So first of all, what is hepatitis C? So it's a virus, which I like to play with toys, so this is going to be my little virus today. It's going to be a single-stranded RNA virus that comes from the family of Flaviviridae. This is not disease that you get from having intimate relations with flav. What this is flavus means yellow in Latin, and it's named after a group of viruses like yellow fever. This is going to include dengue fever, West Nile, and Japanese encephalitis virus. So HCV is approximately 50 nanometers in size, so it's a pretty small virus, and it lacks a proofreading polymerase, which allows for multiple mutations that can happen in it. In HCV, there's actually 6 different genotypes. We're going to talk about genotype 1 because it's most relevant to the U.S. It accounts for roughly 60 to 70% of all cases in the U.S. and up to 60% worldwide. There are other cases or other genotypes that we could go over. Genotypes 4 through 6 are similarly treated as well as genotype 1. So we're just going to focus this entire presentation on genotype 1 for the sake. And the other thing we'll mention is that the virus basically replicates within the hepatocyte, so that's where we're going to focus the rest of this as well. So let's talk a little bit about some pathophysiology here. So what's going to happen in an acute HCV infection? You're going to have the virus that's going to cause the viral load to rise in the hepatocytes. Now this rise in the viral load is going to cause natural killer cells to activate. Now the body wants to compensate for this by eliminating this viral load, so it does it by a co-expression of several different things. You have your HCV-specific CD4 and CD8 lymphocytes, as well as T lymphocytes, as well as interferon that's co-expressed to help decrease this rise in viral load. So then your bodies want to eradicate the HCV. So it does this by either inducing apoptosis in the hepatocytes or also by the interferon that's co-expressed to help stop the viral propagation. Now, hepatitis C does infect less than 10% of all hepatocytes. However, it does activate up to 20% of the hepatocytes for apoptosis, so there can be widespread liver damage. So, hepatitis C is the most common blood-borne pathogen. It infects approximately 3.2 million people with chronic infections throughout the U.S. Roughly 16,000 acute cases in the U.S. in 2009, and it stays within about that range between 15 and 17,000 cases a year. Most of these patients do not even realize that they have it, and we'll talk about why later. The important thing that I want to point out now, which will play out through the course of this presentation, is hepatitis C is very prevalent in high-risk populations. And what do we mean by high risk? Well, we're talking about prisoners, intravenous drug users, which you'll see is abbreviated IDU, and the homeless population. Now, this is important because these 3 populations are typically eliminated from any kind of surveys that are done in regards to anything healthcare related. So these numbers that we have as estimates can be skewed. They can be significantly higher because we don't ever really account for these populations as well as we should. So let's take a minute and play a little guessing game here. I want to bring a little real-world perspective to it. So we know that it's going to be common. Well, here's some famous celebrities that we have that have been known to have hepatitis C. So in the first picture here, can anybody tell me who the lead singer is? All right, what band? All right, this was taken from the Super Bowl halftime show this year when they were faking. All right, second picture. Who is this? All right, let me tell you how hard it was to find a decent picture I could use for this presentation. It took hours. That was a lot of fun. So, in Black History Month, who is this third person that we need to be aware of? James Earl Ray, Bill Martin Luther King. So he had hepatitis C. Medical field, who's the guy in the corner here? Why do we know him? He was a proponent of euthanasia. All right, Jack Kevorkian, he said that he got it because he was testing blood transfusions from the Vietnam War. That's how he thinks he got it. Pamela Anderson got it because she liked using tattoo needles from Tommy Lee. We know he has everything in the sun. Dad, this one's for you. Who's this guy in the middle? One of the best baseball players ever, right? All right, yeah, he played back in the 50s for the Yankees. So, and then who do we got here in the end? Evil Knievel. All right. So he came down with hepatitis C from a blood transfusion after he had a really bad motorcycle accident. So that's how he ended up getting it. Now, one other thing I want to mention, there's a lot of musicians, and I only put Anthony Kiedis as one musician on here, but a lot of musicians tend to get it because they have a history of intravenous drug use. And a few that I'll mention, some of these, most of you won't know, but I'm going to mention them anyway. David Crosby from Crosby, Stills, Nash, and Sometimes Young, as well as the Byrds. Greg Allman from the Allman Brothers. Bill Lesh, which was a bassist from the Grateful Dead. Keith Richards from the Rolling Stones, who ironically said he never treated it, that he just cured hepatitis C for just being him. So next month, Keith Richards' beer will probably be out. And then Steven Tyler for Aerosmith. They all got it from intravenous drug use. So let's talk about some causes of HCV. We mentioned a few here. So in this chart, you'll see this big old green Pac-Man thing going on here. This is intravenous drug use. It's going to account for more than half of all cases. We've got in the blue 15% counting for sexual reasons, transfusions, which are not really relevant now because in 1992 they started testing for this. But I did want to put it in here for completeness that it did account for roughly 10% of all cases at that point, which is pretty significant. There are idiopathic concerns, occupational hazards like needle sticks, which is important to us in the healthcare field, accidentally getting stuck from that. And then the other population, we can talk about, it's a small percent, but hemodialysis, talk about vertical transmission at birth, which vertical transmission can account for up to 4% of cases, but that number can be higher when dealing with co-infection with HIV. So let's talk about some screening guidelines here. There's several here. I'm not going to read all of them to you, but you'll again see intravenous drug use. So if you have a current past history of that, go get screened. HIV is going to play out through the rest of this presentation, so just be aware of that. There's a couple of other things here to be aware of. The biggest thing is for the baby boomers, this last one right here. The CDC does recommend a one-time screen if you were born between the years of 1945 and 1965. It was just a fun time back then, so they think everybody's just going to get tested at least once. Now, this is done if you ever donate blood. They do run a screen for that then, so donate blood. So let's talk about some of the presentation of what can happen in patients when they present with hepatitis C. So first of all, the big number that you got to see here is 70 to 80% of patients are asymptomatic. So that's why our numbers of estimates of people that have infections are so skewed. We have no idea. Most people don't even know they have it. And it's such a slow progressing virus too, because it can take anywhere from 20 to 30 years for the first initial infection to even lead to the point of being cirrhotic, so causing cirrhosis in the liver. So symptoms can appear as soon as 1 to 2 weeks after exposure and as long as 6 months. But the average time is about 6 to 7 weeks after exposure to start getting some symptoms. And the viral load is actually detectable in the blood within 1 to 2 weeks after the exposure. And one factor I do want to point out is their ALT levels can exceed 10 times the upper limit of normal. There are some mild and moderate symptoms to be aware of, which are pretty common, some things like fever, fatigue. You can have loss of appetite or anorexia, nausea, vomiting, abdominal pain, dark urine, clay-colored bowel movements, joint pain, jaundice, which will show up as yellowing of the skin or in the eyes. Now, what does this look like long term? So out of every 100 people that are infected with hepatitis C, 75 to 85% of these acute infections will develop into chronic infections. And again, most of that is because patients do not know that they're infected, so they don't seek treatment, and things start progressing down the line. Now, these 75 to 85%, 60 to 70% turn into chronic liver disease, 5 to 20% turn into cirrhosis, and 1 to 5% can die from the cirrhosis or hepatocellular carcinoma, which is going to be HCC. And roughly 15,000 deaths occur per year due to liver disease that have stemmed at some point from hepatitis C. It's the leading cause of liver transplant in the United States. Now, let's talk about historical, what has been used to treat hepatitis C infections. So the standard of therapy prior to 4 weeks ago today was a 3-drug treatment. You had Simeprevir or Simeprevir, pegylated interferon alpha, and ribavirin. And these drugs were indicated for treatment-naive, null or partial responders, and patients that relapsed from treatment. And you had several drawbacks to all of this. Did want to mention Simeprevir and Simeprevir are protease inhibitors. Ribavirin is a nucleoside inhibitor that stops RNA synthesis as well as messenger RNA capping. And so these drugs, you have to take quite a bit of medication, which I'll talk about in the drawbacks for these in just a second. But you've got several drawbacks. You have the adverse effects with these protease inhibitors. The biggest side effect that's going to be seen in upwards of 50% of patients is going to be fatigue. You're going to have fatigue, rash, and a lot of other symptoms. The big 3 things that you got to worry about are going to be the skin reactions, which you can actually have as Stephen Johnson's toxic TEN, erythema multiforme. A lot of those you can also have dress reaction to it, which we learned about in PBM not too long ago. And then you've got a lot of nausea, vomiting, and diarrhea that comes out of that as well. Now, the pegylated interferon and ribavirin, you're going to have similar adverse effects to this, as well as additional ALT increases. You're going to have some depression, some injection site reaction. That's going to come from the interferon because it's a subcutaneous injection. Ribavirin is an oral medication. And then you're going to have some hepatic decompensation. So those are things that we want to look out for. Now, the drug-drug interactions with the protease inhibitors, the classes of drugs to be careful for are going to be statins, CYP3A4 inducers or inhibitors, contraceptives, systemic corticosteroids, PDE5 inhibitors, and anticoagulation, antiplatelet medications. You're also going to be aware of HIV medications, which we mentioned earlier. There is a high incidence of co-infection with HIV and hepatitis C. A lot of that has to deal with high-risk populations. So in the HIV medications, we're looking at a lot of the older classes of drugs, the protease inhibitors, the NRTIs, the NNRTIs, and even maraviroc, which is a CDCR5 entry inhibitor. The pegylated interferon, really concerned about zidovudine, and then you're going to have increased toxic effects from the ribavirin. And then ribavirin, you actually have a contraindication with didanazine, which is an HIV medication, as well as zidovudine, both of those being NRTIs. You're going to have hepatotoxicity or lactic acidosis from those medications by taking them. Now, the other big thing that we want to talk about that's a big drawback is you have a huge pill burden with this regimen. With Simeprevir, you're taking 6 pills a day. The therapy comes as 1,125 milligrams every 12 hours or 750 milligrams 3 times a day. So you're either taking 2 pills 3 times a day or 3 pills 2 times a day. 6 pills a day. It's a lot for just one drug. Simeprevir is going to be 800 milligrams 3 times a day. It comes in 200 milligram capsules, so you're talking about 12 pills a day. The ribavirin is another oral medication that's going to be 4 pills a day. And so when you look at it, you're going to have the pegylated interferon is a once-weekly injection. So you're either going to be doing 10 pills a day if you do the Simeprevir and ribavirin, or you're going to be doing 16 pills a day if you do Simeprevir and ribavirin. So that's a lot of medication. So one of the reasons why we like having new guidelines come out, new drugs come out, is trying to decrease that. And then the other thing we have to be aware of is ribavirin is pregnancy category X. So anything that's used in combination with these drugs is going to be teratogenic, and so we don't want to use it in any pregnancy or lactating women. Now, Simeprevir, this is the new drug that we're talking about. This drug was approved in November 2013. It's indicated right now for the treatment of genotype 1 chronic HCV infection in treatment-naive patients. It's dosed as a 150 milligram capsule a day, and it's to be used in combination with pegylated interferon and ribavirin. So already we're decreasing the number of protease inhibitors that we were doing with the old regimen, dropping it from 6 pills or 12 pills down to 1 pill a day, just with that drug. So that's already a huge step. The duration on this is going to be 12 to 24 weeks based on response-guided therapy, which I will go over the standards on that now. Basically, for the first 12 weeks, you want to look at a viral load to see the marker is 25 units per ml. And so if you're above 25 or at or above 25 units, then it's going to be detectable. If that's going to be undetectable. So if you're detectable after week 4, you're going to discontinue all therapy. After beginning weeks 13 through 24, if you're detectable at week 12, you consider that your Simeprevir treatment is completed, and you will continue the pegylated interferon and ribavirin through week 24. If your viral load is detectable at week 12, then you're going to discontinue the whole therapy. So you should pretty much be undetectable by weeks 4 and 12. Those are the 2 markers there. So we're also going to talk about some monitoring parameters with Simeprevir. One of the side effects of it is you can have hyperbilirubinemia. You're going to have elevated liver enzymes. With this drug, it's more in the outphos as opposed to ALT. You're going to have some increased uric acid. Pregnancy test, we want to monitor, again, because we're using it in combination with ribavirin, which is pregnancy category X. And then we're also going to monitor viral load at the points that I mentioned a moment ago. So we're going to talk about the mechanism of action first. And if I can have my volunteers come up, we're going to do a little demonstration. I'm a visual learner, and again, I like playing with toys, so this will be fun. Okay, 2 ladies here are going to be my strands of DNA, which we're going to represent with Uno cards, representing the 4 bases that DNA has. All right, 2 gentlemen here are going to be my non-structural proteins that our virus is going to code, non-structural proteins 3 and 4A. Now, each of these are serine-type proteinase, and they're going to form a complex. So in this complex, it's been termed the Swiss Army knife. And so what they're going to do is it's going to travel in the system, and it's going to cleave peptide bonds. So cleave the bond. Then when it cleaves the bond, it's going to inject the viral mutation, the RNA, into the DNA, causing the change. So, let's talk about what happens whenever. So, when you take Simeprevir, what's going to happen? Well, you take away the Swiss Army knife. And you take away the ability to pass along the viral message. So when it goes through, you leave your DNA alone. It's preventing any kind of changes, any kind of mutations to the DNA, so therefore viral replication is not happening in the hepatocytes. Give a quick hand. All right. So this class of drugs, more or less, is going to be abbreviated as DAA, which is direct-acting antivirals. And its mechanism of action is a non-structural 3,4-A protease inhibitor. So let's look at some pharmacodynamics and kinetics with this medication. So first of all, food is going to enhance absorption, which is important as a counseling point. It's also highly protein bound. It's actually above 99%. It's going to be metabolized primarily by the CYP3A4 enzyme system, as well as there's some possible metabolism with 2C8 and 2C19. In healthy patients, the half-life of the medication is 12 to 13 hours. However, in HCV-infected patients, it is up to 41 hours, which is the reason why it is only dosed once per day. Now, the time it takes for the medication to get to its serum peak concentration is going to be 4 to 6 hours, and it's going to be excreted mostly in feces with less than 1% in the urine. So we do not have to do any renal dosing with this medication because it is going to be in feces. Now, some side effects to be aware of with Simeprevir. Again, you're going to have a possibility of skin rash, some nausea, the hyperbilirubinemia that we talked about, some myalgia. You can see all the other things on here. The three important things I want you to remember are going to be in regards to the skin rash, the photosensitivity that can happen, and the sulfa allergy. And I mentioned the photosensitivity and the skin reaction because it's actually higher in East Asian populations. They have higher serum exposures to the medication, so they can have a higher incidence of those first two major effects. The sulfa allergy, there's a sulfonamide moiety, so anybody that has a sulfa allergy, there's not a higher incidence of that happening, but it's just a counseling point to be aware of. Now, as far as drug-drug interactions, like the other protease inhibitors we talked about earlier, you want to be careful with statins with risk D. You've got your CYP3A4 inducers inhibitors, which are risk category X. Your PDE5 inhibitors are going to be risk C. That basically means we just need to use caution when using these medications because we know how the miracle drugs, Viagra and Cialis, are being used right now, how often. In HIV medications, when used in combination with other protease inhibitors, it is it's a risk category X. And with tenofovir, it is a risk category C, so we want to do some additional monitoring of that. So even though there is a high incidence of HIV infection, we just want to consider using a lot of monitoring. With the protease inhibitors, we don't want to use that class. We may want to use the integrase inhibitors, which are a newer class of drugs that are out as alternate form of therapy and all of that. Other warnings, the Simeprevir is a pregnancy category X because it's used in combination with ribavirin. It does not have, I could not find its specific pregnancy category by itself. However, the other drugs, the new drugs that are coming out of pregnancy category B, and they think this is probably going to be there, but there's not enough testing done just because nobody likes to be tested when they're pregnant. So the big thing is we want to make sure we're monitoring for pregnancy tests before we start treatment as well as while we're on treatment. And we want to use two forms of birth control during and up to 6 months after the start of the medication. Like I mentioned, the Eastern Asian descendants have a higher exposure. And so contraindications for use are going to be based off the pegylated interferon and ribavirin, which with pegylated interferon, contraindications are going to be hypersensitivity, autoimmune hepatitis, decompensated liver disease with a Child-Pugh score of greater than 6, class B or C, and a co-infection with HIV, as well as neonates and infants. Ribavirin is pregnancy, no partners of pregnant women, and hemoglobinopathies like thalassemia major and sickle cell, and concomitant use with diadenosine. So before I get into clinical trials, I'm going to show a few abbreviations and phrases that we may use just to make things a little bit easier. So CEVR, complete early biologic response, we're going to refer to by week 12. I may use HCV-RNA, I may just call it viral load just to be a little bit easier. Response-guided therapy we talked about earlier is monitoring at weeks 4, weeks 12. Rapid virologic response, RVR, that's going to be seen at week 4. And then I'm going to call triple therapy the use of Simeprevir with pegylated interferon alpha and ribavirin. So let me just call it triple therapy. So the first study I'm going to look at, you see the name of it. We're going to call it the DRAGON study. And I think it's awesome whenever studies have these really cool abbreviations. We always know what they are. They just pick random letters and just call stuff. So there's what DRAGON stands for. So the DRAGON study is a multi-center, randomized, open-label, parallel group comparison phase 2 study that was performed in Japan between July 2009 and April 2011. And this is where they found that the higher Simeprevir exposures were done in Eastern Asian patients. So the study was designed to evaluate the efficacy, safety, and pharmacokinetics of Simeprevir used in combination with treatment-naive patients, and it's based on the Japanese versus the Caucasian healthy volunteers that were demonstrated in earlier phase 1 studies. Now, in this study, they used there was 5 treatment arms. So we're going to look at 50 milligrams and 100 milligrams. And then you're going to have a treatment arm that's just the pegylated interferon and ribavirin as its own arm. So you got some inclusion and exclusion criteria here. So the big things, again, treatment naive, chronic genotype 1. We're talking about adult patients here with a viral load of at least greater than or equal to 5 logs of screening. Exclusion criteria is a lot of liver damage, organ transplant, HIV co-infection, or meeting any contraindications in regards to pegylated interferon or ribavirin treatment. So we mentioned 5 treatment arms in a 2-to-1, 2-to-1-to-1 ratio. You see the dosing here. Simeprevir for 12 weeks, pegylated interferon or ribavirin for 24 weeks, 24 weeks and 24 weeks, and then you've also got 48 weeks. So the therapy duration was based on the response-guided therapy at week 24, and this criteria did not apply to the pegylated interferon and ribavirin group by itself. And there was a follow-up period of 24 weeks after the end of whatever therapy patients were on. So the primary endpoint is going to be our SVR, which is a serologic virologic response at 24 weeks after the end of therapy, and that's not at week 24. Secondary endpoints are going to be a proportion of rapid virologic response at week 4 or the complete early virologic response at week 12, and then a change in the viral load from baseline at week 4. And they're going to measure all of this through plasma viral load and ALT levels done in a blood test. So at the start of the study, there were 116 patients that were screened, 92 were randomized, and the ratio we talked about before. Half were male with a median age of 54 years and a median body weight of 58 kilograms. So these patients were a little on the thin side, no big guys like me. Did have a median baseline viral load of 6.3 logs, and 7% displayed a Simeprevir fibrosis score of stage 3 but no stage 4. And what this is a screening or a score that's done to assess the level of fibrosis in the liver. It's a 5-point scale ranging from 0 to 4, 0 meaning no fibrosis, 4 meaning complete cirrhosis. So stage 4 would have been contraindicated to the exclusion criteria if stage 2 was okay. All right. So here is some results of our primary endpoint. The first row is going to be all patients that were done. The second row is going to be patients that completed successful therapy. You can see the rates, 21 that reached it, 21 was the total number in the group, versus 20 that reached it, and 24 that completed success. You can follow the numbers throughout. The trend we notice here is when patients that were on Simeprevir, they reached the primary endpoint 77 to 92% of the time, as compared to the control group, which was only 46%. And for those that successfully completed therapy, you can see rates of approximately 90% throughout, which is statistically significant. Also, we're looking at all of our endpoints, primary and secondary endpoints as a whole. Undetectable at week 2. We already had a response of 28 to 44% by the second week, whereas there were none in the control group. You can see you have statistical significance in several of these figures due to your p-value being less than 0.05 compared to the control group at 48 weeks. And they determine this also using the Fisher's exact test. One way of showing meeting and secondary endpoints of the RVR and the complete PVR is going to be by doing the lean status mean changes, which we did not learn in our classes here. So the best way that I can explain it is it's a way of analyzing data to best fit the data set, and it's going to be used in lower population sizes. When you have lower population size, you can have unbalanced data, so it's going to help balance the data out, and it's also going to remove bias. So what we're showing here is there were 5 logs greater difference in patients that are doing Simeprevir versus just under 3 logs difference on the control group. And then again, here we're seeing reaching RVR at week 4, 83 to 90% versus 8%, and statistical significance at week 12, only 90% versus 50s. So talking about some discontinuation of therapy, we had 9 patients in all of the Simeprevir treatment groups that discontinued. Most of them were due to adverse events. Hyperbilirubinemia was the biggest reason, a grade 3 or 4, which is by the WHO standards, which is pretty significant. There was one death of a cerebral infarction in a 64-year-old female. Her only confounding variable was the fact she had hypertension. They determined this was unrelated to therapy, but the death did occur. In the control group, there were 3 patients that discontinued. 2 were due to adverse effects. 1 was to another reason that was not listed. Again, we talked about the big side effects with skin reactions. So of note, there were no grade 3 or 4 skin reactions or decreases in hemoglobin levels. Also in the Dragon study, it's important to note that even though they were aware that the hemoglobin could drop, EPO, erythropoietin, was not indicated for use as any kind of rescue therapy. So as far as the study goes, the authors did determine there was significant improvement in the SVR, which is the primary endpoint in the treatment groups as opposed to the control group. There was shorter overall treatment duration. There was a reduced risk of adverse events that were experienced, and they determined that it was a cost-effective alternative therapy option, which I'll go to in a minute. I don't necessarily agree with that. The RVR at week 4 was highly predictive of the SVR, so if they started getting a high RVR rate, then it was pretty predictive of meeting the primary endpoint. And so that from here, they took the significance of the 100 milligram dose for the 12-week duration and moving it forward into phase 3 trials. They did determine that larger phase 3 trials would be needed. So a couple of strengths in the study. I did think the study design was a strong point because it was randomized, it was a controlled trial. It was a good ratio of men to women because in practice you will find that it's pretty even when it comes to infection. It doesn't affect more men than women. It's pretty even, so I thought the ratio is important. And the statistical analysis that we used, I also thought were important as far as showing significance. As far as weaknesses go, I think a small sample size, we had less than 100 patients. It was done in the Japanese population, but I do think a larger sample would have been needed to extrapolate information. That's just a phase 2 trial. So we'll go ahead and move on to our second study, which we'll call the pillar study. Again, there's a nice abbreviation for the pillar study, just picking out random letters. In the pillar study, this was also a phase 2 study. It was a multi-center international double-blind randomized placebo-controlled trial conducted from May 2009 to April 2011. It was designed to test the efficacy and safety of Simeprevir used in triple therapy combo as compared to pegylated interferon ribavirin alone. So we have similar inclusion-exclusion criteria. Viral load of at least 100,000 copies. They had to be eligible for the interferon-based therapy. Again, no cirrhosis, liver disease, platelet count did not be less than 90,000 because another side effect you can have is thrombocytopenia. And then we have some exclusion criteria regarding hemoglobin as well, which is male and females. Also had 5 treatment arms done in an even ratio. This time we're using 75 milligram doses of Simeprevir for 12 to 24 weeks, as well as 150 milligrams in the same time period. There was also the placebo that was given for 48 weeks with pegylated interferon ribavirin. Those Simeprevir 12-week groups did receive a matched placebo after 12 weeks of therapy. So the first 12 weeks they would take the treatment drug. The next 12 weeks they took the placebo, and then completed the 48-week regimen overall using the peg and riba from that point on. Again, we're using response-guided therapy. We're dealing with the medication for treatment up to 48 weeks. And then we had a follow-up period again of 24 weeks after the end of therapy, so a total follow-up of 72 weeks of therapy, which that would be our primary endpoint, was what the SVR was at week 72. Secondary endpoints are with patients reaching SVR weeks 12 and 24 after the end of treatment. And then the authors determined that 80 patients would need to be randomized into each treatment group to provide a 77% power, which I thought was low, to detect a 25% difference in the SVR 24 weights between groups. And then we did use intention to treat analysis performed on here to study for significance. At total, we had 506 patients that were screened, 386 were randomized, and if you'll notice, we did not reach our numbers that we needed to reach power. Mostly males, we had a higher incidence in each of the treatment groups, ranging anywhere from 51 to 63%. Mostly Caucasians, 90 to 96%. And I think the highest group, as far as blacks, was 2%, Asians was 4%. Median age, 84, body weight was kind of low. And then again, we had viral load similar to the last trial, at baseline 800,000 units, and then a Simeprevir score of 3, which, like I mentioned before, level 4 is, or score 4 is for cirrhosis. So we had a higher incidence of grade 3. However, in this study, they did goof. There was one patient with a Simeprevir score of 4 that snuck in after biopsy. They didn't catch it until the 13th day of therapy. The patient was excluded from that point, but his information was still included in the trial because the intention to treat was still used as information. So here we're going to look at all of our results in a nice pretty graph. Our primary endpoint is here at week 72. And then we have our secondary endpoints on the end. We're just going to look at trends. The placebo group is the burnt orange round color here. We're roughly 60, about 2/3 of patients received it in about the 48 week. The other groups were all in the 80s, roughly. As you can tell, from 12 weeks to the end of therapy to 24 weeks to the end of therapy, the numbers are pretty much the same. So I think this is important clinically because we're talking about 24 weeks of response-guided therapy with Simeprevir. There's really no difference between 12 to 24 weeks. So we're actually going to start looking, going forward into guidelines, they're going to look at this information and cutting duration time. And of these numbers that reached statistical significance, we had a p-value of less than 0.05 versus the placebo and the pegylated interferon and ribavirin group. They did find statistical significance in the 12th week, in the 75 milligram dose, it's 83 here. And then in both of the 150 milligram groups here, they found statistical significance as well. One other thing I do want to mention is even though we did not reach our treatment size that we needed to reach power, one could argue that how we had a larger group, that the 75 milligram dosings could be used to, they could have reached statistical significance, but because we didn't reach power, that's why those were not determined. So one other significance that we found in this study, in the pillar study, is there is a polymorphism of the Q80K, and they found that 10 of 12 patients that were determined to have this polymorphism failed treatment due to viral breakthrough or relapse. Also, there were some adverse effects that were seen throughout the course of the study, the most frequent being fatigue, flu-like symptoms, pruritus, headache, and nausea. These were associated with the pegylated interferon and ribavirin, more so than Simeprevir. And these incidences of adverse effects were similar across all treatment groups, including placebo. So again, some discontinuation information. There was not any grade 3 or 4 anemia in the Simeprevir group as there was one in placebo. You can see as far as rash and hyperbiliary anemia, it was a little bit higher in the treatment group as compared to control, but there were not any deaths in any group reported in this trial at all. So statistical significance of the high response rates in the 150 milligram Simeprevir group was seen as the optimal dose to move forward for use in phase 3 trials. 12-week Simeprevir treatment group was deemed most appropriate for use in the phase 3 trials as there was no additional benefit seen at week 24. There was no firm relationship made at the time between the presence of the polymorphism and the lower SVR rates due to the fact that it was just 12 patients. They did think that it may be significant. So now in the guidelines, they are recommending when you start Simeprevir to be tested for this polymorphism. And again, they did determine that larger phase 3 studies were needed. So in the strengths, we had the study design, double-blind, placebo-controlled, randomized controlled trial, intention to treat analysis, some weaknesses, mostly Caucasian patients, which I thought wasn't representative to what happens in a real-life setting, because again, going back to the high-risk populations, So I think there's a lot more minorities that tend to have it than was used in this study. I did think that a weakness was the fact that the Metaphor score 4 patient did slip in there, and it took him 13 days to figure it out. So his information was basically still included in the study, but kind of showed a lower rate. And the fact that I put sample size on here because we didn't reach our power. I think there could have been some more information that could have been seen had we had a larger group. So we're talking about some additional studies, because both of these trials were phase 2. So if you go to clinicaltrials.gov, you will find there are 47 trials that are going using this drug right now in a variety of facets, including use with HIV co-infection. So the three important ones I want to pull out are the Quest 1 and 2 studies. They're both global phase 3 placebo-controlled, double-blind, randomized trials. Some interim results that have come out from them, they have not been published, which is why I'm not formally presenting them, but I'm showing you the information that was presented at the AASLD conference back in November. They found 86 and 91% patients meeting the response-guided therapy at 12 weeks after the end of therapy, as well as there was use in Simeprevir 3 and 4 patients, which we're again talking about extensive liver damage, which in the phase 2 trials, again, Simeprevir 4 was contraindicated. So at least 2/3, 66 to 70% with extensive liver damage still reached primary endpoint. That's significant. Cosmos study. This study is a phase 2 open-label randomized study. The important thing to know about this is the Quest 1 and 2, again, we're still using pegylated interferon and ribavirin in combination with triple therapy. So what do you do when you have patients that can't use interferon? Well, that's the good thing about the Cosmos study. We're talking about patients that are using Simeprevir, as well as a newer drug that just came out, sofosbuvir, which Josh presented 2 days ago in a different class. And they're looking at this with or without ribavirin therapy. And they were measuring SVR after 4 weeks at the end of therapy, 12 weeks of total therapy. If you look at your numbers here, 96 to 100%. That's pretty awesome. So, with these new trials, the trials that I presented, as well as the 3 that we just went over, it caused the historical guidelines to basically be thrown out. They changed them all up 4 weeks ago today. So, what happens? They're looking at whether or not patients are still eligible for interferon therapy. Big drug here, sofosbuvir. They're looking at it here in ineligible patients using it in combination with recommended therapy with or without ribavirin for 12 weeks. That's based on the Cosmos study, 96 to 100% of patients reaching SVR. Alternative therapy, we're talking about my drug here. Simeprevir in 12 weeks of therapy, using in triple therapy for 24 weeks as alternative treatment. And then no longer are we using sofosbuvir or Simeprevir. No longer are we doing the 48 weeks of PEG and ribotherapy. And then we don't do monotherapy with any drug whatsoever. We're still wanting to do 3 drugs. And then we do not want to treat decompensated cirrhosis with interferon or Simeprevir. So the big thing, cost. How does it affect me in the pocket? Because that's what I'm most importantly concerned about. A lot of numbers, I'm not going to go through it, but what I'm going to show you here, Simeprevir in triple therapy, we're talking about a cost of $1,900 per SVR percent, going from 55 to 90%. I can't afford that. I'm a college student. In the recommended therapy, based off the Cosmos study, we're looking at a total cost of almost $160,000 for 24 weeks of therapy to reach 100% SVR. But again, you're looking at roughly $3,000 per percent, which is just ridiculous. So, we're looking at the pharmacist's role here. What's important? Community screening and education. Talking about counseling and medication compliance in regards to adverse effects of drug interactions. The cost analysis, like we talked about. Our insurance is even going to cover it. With the Affordable Care Act, are they even going to cover it? Chances are no. There is some patient assistance out there from manufacturers. However, they only cover up to $25,000 of the maximum benefit, which is 1 month therapy on a new drug. That's not going to help when you have to take it for 6. And then proper occupational training. Again, that's going back to one of the causes like needle sticks. We want to make sure patients or employees are properly trained. And then how does this apply to pharmacy practice today? So you have new drugs that are coming out, which I'm not going to talk too much about. You can see how they work. And then again, it's important in pharmacy practice as far as cost goes. In a hospital setting, to see if we need to put it on formularies, to see in a community setting, what are we going to do for these patients that can't afford it. So Jerry Springer always does the final slide. So I'm going to do a couple here. Things that I thought of that were important are high-risk populations. They're uninsured, underinsured. They can't afford these new therapies that are recommended in the guidelines. So it's great to have a miracle drug, but what do you do if you can't afford it? Nobody can pay for it. And all the other therapies are no longer recommended. So co-infection, HIV and chronic hepatitis C, it's prevalent in these high-risk populations, yet treatment options are limited. There are studies, but we still don't know what's different. So the potential of this new therapy here, sofosbuvir and Simeprevir, and not using ribavirin, which is the pregnancy category X, we need some studies done on it in pregnant patients. Could there be some benefit in treating pregnant women going forward to prevent vertical transmission? Which again was a low percent, but that helps. And unless any one of y'all are Bill Gates or Warren Buffett, the high cost of these new guideline medications is prohibited for most patients. Ultimately, we got a miracle drug. A lot of people can afford it. Not a lot of insurance is covered. So at the time, I don't think the benefit is worth the cost. Here are my references, the ones I use for my pictures. And I have my email address here if you have any questions. We'll open it to the forum, but you can always email. Yes?
Well, what if the patient is treatment naive and they never received treatment for their HCV, but they got HCV like a few years ago, now they're in the terminal stage. Would you personally recommend using them?
So I will go back to say that it does take 20 to 30 years for it to reach cirrhosis. So one of the screening guideline recommendations is for the baby boomers that were born between 45 and 65. Let's say somebody then had a very high-risk lifestyle then. They've been asymptomatic to this point. They find out that they've got it and they have a cirrhotic liver. So with the information from the Quest 1 and Quest 2 trials, they're showing that patients that do have a Medivir score of 3 or 4 are showing at least 2/3 benefit of reaching SVR. So I do think if you can afford it, then yes, it is a viable option. Now, also with the guidelines, they are doing some studies in using it in patients that are null or partial responders or patients that have failed treatment before. So there are phase 3 trials that are ongoing right now in dealing with that. But the data is not out yet. They have not completed those trials to show if there's any benefit. So to answer your question, yes, I do think it would be beneficial to go ahead and use it if you can afford it. Yeah.
What is Q80K?
Q80K. It's a polymorphism that's done in the DNA. As far as what it specifically does, I couldn't tell you. I didn't look enough into it. However, I would be more than happy to look into it.
No, I couldn't do that.
Not off the top of my head. That was getting too far down the rabbit hole. I was trying to stay out of it.
There's a difference in the trial for the one study and the medication that we get for the dose. And that would recommend a difference based on where there was a difference in the
Okay, so your question is, in the Dragon study, when they tested on Asian patients, they used it on lower dose, and in the Pillar study, they used a higher dose. And you're asking if I would recommend a dose?
Yeah, there's a difference. There's a mention.
Okay. So Simeprevir only comes in one way, which is 150 milligram capsule. So when they did the Dragon study, even though the Dragon and Pillar studies were going on at the same time, they were using different doses at that time to determine what dose would be effective. So they used the 50 and the 100 milligrams. And from that study, they found there were better response rates with the 100 milligrams. So they used the fact, okay, more is better. Let's push that into phase 3. So that's why when they put in the Pillar study, they tested the 150 milligrams. Found that was statistically more significant than the 75 milligrams and pushed it further into getting approval. Any other questions? Okay.
one of the drug interactions with Simeprevir is statins in the liver disease. Would you consider, and this if the patient was not Simeprevir, would you consider that therapy in patients with the
Okay, so the question is if a patient is having or using statins for therapy in patients, whether or not they're using Simeprevir, if they do have cirrhosis of the liver.
If they have an indication.
If they have an indication, I would still, yes, I would consider use of statin therapy with caution. I would look at what levels they have, see if they need low to moderate, what type of therapy they need, but I would still consider if they are indicated for use. Yes.
In your background, you mentioned the process of HIV, the trial is over to medication. Can you explain why the patients are later with the substance use?
It has to deal with the drug-drug interactions with heart therapy, mostly in concerns with the protease inhibitors, with a couple of the NRTIs. So they found as far as to have a more standard therapy, because there are so many HIV medications that are out there, it would be hard to figure out what benefit would be seen. There'd be too many confounding variables, more or less, with all the different drugs that are being used. We have so many different classes they couldn't account for any benefit with that. So they didn't use they use that as exclusion criteria. Now in the newer trials, in the phase 3 trials, they have started doing a lot more testing. I want to say I saw 20 different trials that were testing co-infection. But again, the 2 trials that I formally presented were phase 2, so they were just looking at more of just the safety and efficacy as opposed to looking at more or less co-infection. I don't have a number to give you, but it is a high percent, and it goes back to the high-risk lifestyle. There's a lot of intravenous drug use. A lot of patients can get infected with HIV through intravenous drug use, and some of that. So there's a lot of the causes kind of cross over. So that's why you have a high prevalence of it. Yes. Yes. Any other questions? Yeah, you guys have your quiz you can take.
So did they account for in their study, did you mention they had to respond to that? Was that, I was a little confused, was that just for Simeprevir or did that include Simeprevir and
They were looking at it for triple therapy. It was more concerning the PEG and RIBA because in the phase 2 trials they were looking at 48 weeks of therapy. But you're also looking at it with Simeprevir because you're going to look at weeks 4 and 12, and by week 12, if they're undetectable, then you're going to stop Simeprevir treatment at week 12. If you're still detectable, then you could proceed on to week 24.
And did they meet that threshold?
Yes.
So did they stop Simeprevir and
If they stopped one, they stopped the whole thing. Yes.
And how did they account for that in their results? How did they account?
They actually, I forgot to mention it, but they used ANCOVA and used that as the confounding variable. So that's another way that they do significance. They use Fisher's exact test as well as ANCOVA. ANCOVA is other ways back.
I just want to make sure I'm clear on the final thought. Correct me if I'm wrong, but I thought your conclusion was that the risk or cost outweigh the benefit, so you would not recommend that at this time. So A, is that exactly what you said? And B, how do you reconcile that with the new guidelines that I guess show reference analysis?
Okay, so your question, if I understand correctly, is you want to verify cost versus benefit in relation to the new guidelines. if
Well, your conclusion.
right, my conclusions in comparison to the guidelines. Okay, so the guidelines, they state as recommended therapy doing Simeprevir, sofosbuvir, and plus or minus ribavirin. That's based on a costal study. With that therapy, you're looking at roughly $160,000 worth of treatment. Now, in the guidelines, the authors did have a side note that said they feel that patients probably are not going to be able to afford it. That yes, they can receive SVR rates of 96 to 100%, which is outstanding. They may not be able to afford this therapy. With all of the additional drug classes that are coming out, working in new ways, and with both of these two new drugs only being approved 3 months ago, the cost of them are still really high. And there are even fair pricing coalitions that are out there that are attacking the manufacturers of these drugs for the cost of medications, saying that all hepatitis C treatment that are approved are just exorbitant. Patients can't pay it. So the recommendation is, if you're able to afford treatment, go ahead and get it. It's going to benefit you. It's going to be great. But most people are not going to be able to afford it. So with the introduction of all these new drug classes, with all these new therapies that are coming out, they're saying because it takes so long for hepatitis C to progress to cirrhosis, there is benefit seen if you wait. If you wait on therapy, if you're asymptomatic, you don't have to treat right now. Even in 2 years from now, there could be so many more benefits. The cost could be so significantly less. There could be so more copay assistance programs and patient-assisted health that it could be more beneficial at that point. So, at the moment, seeking immediate treatment, I think you're going to be better off if you are asymptomatic or can at least handle the situation and you can't afford treatment, that you can wait. Even though the guidelines recommend go ahead and do it, I just don't see how patients can afford it. And if you're not going to be able to complete the full 12 to 24 weeks of therapy, then I think it's going to be best that you wait a little bit longer and see if the cost can be better or have more effective medications.
But there's no data. You say there's data that you should wait, or you're saying.
They're saying in the guidelines, they're saying that it is that there's not data that has been published yet that says it, but they're basing it off of patient response. That the progression of the disease in such a short span of a year or two could be more beneficial by waiting in comparison to the cost. And so they do say it's not listed as recommended therapy of waiting. They have recommended treatment options in the guidelines, but they give it as a side note saying that yes, you can wait. Say that again.
Are these two drugs in Simeprevir?
Sofosbuvir?
Yeah.
Mm-hmm.